Good evening, colleagues. It's my honor and pleasure this evening to introduce Professor Norbert Skokauskas. It's a bit difficult to pronounce, but I hope it has been correct. Professor he's known and very well distinguished child and adolescent psychiatry at the Child and Adolescent Mental Health and Child Protection at the Norwegian University of Science and Technology, renowned for his contribution in the field. He also holds the esteemed position of Secretary for Education and Scientific Publication at the World Psychiatric Association. And he has a huge background of research, advocacy, and did work in Ireland before. Professor, the floor is yours. Thank you for accepting the invitation.
Thank you very much, Dr. Walid. Can you hear me well?
Yes, very well.
Thank you very much. And it's a big pleasure and honor to be invited to this online meeting and share some thoughts, some ideas, some original research, and some knowledge which is published by other colleagues on digital psychiatry. So as Dr. Walid introduced me, I am based in Norway. And just trying to change my slides. Can you see next slide or not?
No.
For whatever reason, it's stick to the front. Let me just stop sharing and share one more time. Maybe that would help. I apologize for this technical difficulty, but it always comes when we speak about technology and digital solutions. So the basic technology like PowerPoint does not give us justice. Okay, so I'm trying to share one more time.
It's clear now, but not full slide.
Okay, and now you can see the next slides.
Yes.
Okay, so very good. So I started to complain about technology, but technology works at the end of the day, even the simple PowerPoint. So as Dr. Walid introduced me, I am based in Norway, and we have completely different climate to yours. Winters are very cold, and the summers are hot, but not so hot as in your zone. Okay, so why digital psychiatry is increasingly needed? That's the question we are going to spend some time, because there are a lot of promises and a lot of hopes, but what really it can help us with. So it may improve access to mental health services, particularly in remote and underserved areas. It has the potential to reduce stigma by providing private and discreet treatment options, and could support detection and timely interventions through digital monitoring tools, and may enhance efficiency and scalability in delivering mental health care. So these are the hopes and aspirations that in the near future digital psychiatry can assist us, including personalized and data-informed treatment plans. I'm sure you have come across many types of digital psychiatry. I'm sure many of you used it in your daily practice. I'm not going to speak about all of them. I'm going to speak about the mobile application apps because there is one system we and my team developed in Norway. I'm not going only speak about what we have developed, but I'm going also to inform you, provide some studies which looked systematically, provided systematic review on mobile application and evidence supporting them. And I'm also going to spend some time focusing on the AI, artificial intelligence, everybody is using. Even it says this meeting is being transcribed for AI companion. So even now, as we speak, the AI is working and analyzing us. And I'm also going to speak a little bit about the clinical decision support systems, which I and my team in Norway has been working for a number of years, and we have several PhD students working in that area. And I just want to remind you that my university, we have a medical faculty, but my university is Norwegian University of Science and Technology, which means that my university is the main university for engineers in Norway. And for this reason, in my group, we have engineers and data technologists, and we work on that clinical decision support systems. And then I just going maybe to mention some of these other tools as well. But the most important when we speak about the digital psychiatry and different digital tools is to know the purpose of it. And I think one of the purposes to make sure that our services are sustainable. And by sustainability, I mean the ability to provide high value care now and in the future in the face of environmental, economical, and social constraints. And this is the short paper we published about sustainability on child adolescent psychiatry services in the International Review of Psychiatry, led by the former WPA president. He's an editor, Denish Bogra, of this journal. So let me just provide you some context in Norway, and more specifically to child psychiatry services. And Norway is a relatively well-resourced country, but of course there are challenges. And after talking to Norway, I just give you also perspective to some other countries. So let's say in 2023, we have now the data on 2023, 71,000 children and adolescents receive services from the Child Adolescent Mental Health Services. And if you compare to data from just 2021, so the numbers were much smaller just a couple of years ago. And if you compare to 2020, that 2021 was already increased over 1 year. So at that time, we thought that maybe it was contributed to COVID-19. But the reality is that increase in prevalence started earlier when we talk about the child mental health problems and likely correlate with many factors, including social need, climate change, global instability, economical challenges, and so many other things. And even if we think about countries which we look for the research evidence and different educational opportunities, United States, even in the United States, if we talk about the child psychiatry, we can see that many states are under-resourced, and only the New York and some other states that have the enough numbers of the child psychiatrists, but in most states is severe shortage. And then, when we talk to our colleagues, and this is data is coming from the World Health Organizations in African region or some Western Pacific, the child psychiatrist number per 100,000 is very small. In fact, I have collaboration together with our American colleagues, for example, in Guyana, South America, and they have 2 child psychiatrists in all country. And then I also, together with a few other Norwegian universities, we run 2 projects in Uganda. And then Uganda is much higher population than Guyana, but the number of child psychiatrists is also limited. So the challenge is huge because the pressure is going on the services, and also not only clinical, but this refugee crisis and the war in many areas of the globe conflicts. And we highlighted together with my colleagues about the war as a public health emergency in our short paper published by Lancet journal. This was in 2022, where we highlighted that when there is an armed conflict, it doesn't matter in which area of the world it happens. When there is an armed conflict, we're talking not only about post-traumatic stress or depression, but when we talk about the children, we talk about the effect of these armed conflicts on their developmental stages. Because when there is a conflict, armed conflict, the milieu, the ecosystem for the child, the father, the mother, the school, extended families, all affected. So these global crises also putting pressure on our health system, and we need to find new ways to provide services, and digital psychiatry or digitalization can be an answer to the pressure on the health systems. Just before moving to the digitalization, 1 or 2 thoughts about scaling pressure on the health system, which is universal, not only in one country. I think the case is becoming more and more complex because maybe in your area it's slightly different, but in many European countries and in many North American countries, there is a change in the society, the family structure, the roles, and the challenges was affected with that. There is also great economic inequality. So the people who don't have money, they become poor, and the people who have money, they have more affordability. The social media, seems that so many people on the social networks at the same time, the research shows that there is an epidemic of loneliness. So everybody is connected, but there are so many, especially young people, children, who feel socially isolated and who feel lonely. And even when we talk about the Maslow pyramid, I'm sure we studied all this in our basic training, when we think that the first is physiological needs, that food, water, shelter, clothing, and the self-actualization is the top on this pyramid. You can see that when you talk to the young people these days, children, adolescents, that the self-actualization is becoming so important, that this is a basic need to make sure that you have so many followers on the YouTube, that you have so many followers on Instagram, that self-actualization, self-realization becomes also like a basic need. So some people use that inverted Maslow pyramid as the expression of this changing social media world, especially for our children and youth. And also, when we speak about pressure on the health service systems, I think as a child psychiatrist, I think it's a universal challenges we face when the child gets, or the young person gets 18 or 19, and what is going to happen with him or her. Is he going to go to the adult services? Is he going to see GP? So many children or young people are lost, especially if they have ADHD, because still the adult psychiatrists, not all adult psychiatrists feel comfortable treating ADHD. And then sometimes those children who are lost between the system, adult and child psychiatry, in 20 or 10 years, they come back to the social or justice systems with some social or criminal or alcohol problems because they are lost in between systems, and they did not make that important transitions from the child to adult services. I'm not going to speak too much about the change in classifications, but we know that DSM-11 brought new the categories, and we need to expand our expertise, including gambling and gaming disorders. And stigma, we know that the stigma is decreasing, and that is very good. So people are keen and more openly to seek help for the mental disorders problems. However, this also means that the demand for the services, demand for the mental health services is constantly increasing, and we need to find the ways how to address this need in an effective and efficient way. So digital health or digital psychiatry can be the answer to overcome the pressure on the, I put the child and adolescent mental health services, but I do believe that this pressure applies to any services where mental health care is provided. So what are the challenges related to the digital mental health or digital psychiatry exist at present? This slide summarizes the challenges and the potential solutions. And one of the challenges, varying intervention definition. So people, even in the scientific world, but also in the clinical, they describe the same thing, sometimes just using different definitions. And there is a need for universal definition. There is a lack of consensus on mental illness ontology, and there is no alignment on the digital measurement in research. The integration with the care is a big issue, and I will give my example of my team about the integration which we faced while developing one of the digital tools, and challenges in providing hybrid clinical approaches, so providing both in-person and online care, clinicians training, how to train young people, young colleagues on applying digital interventions effectively. Of course, the young colleagues are very equipped with the technology, but how to make sure that this new tools are provided efficiently and effectively. And obviously, when we develop new digital tools, it's important to have patient engagement and also to comply with the ethical consideration. So I said that my team has worked on the different initiatives, but I will briefly show one when we introduced the enhanced CBT package for children which suffered from obsessive compulsive disorder. And this was actually, we started this quite a few years ago, way before the COVID. And in a sense, we were, as a research project, we were very advanced when the COVID came, because nobody had such a program, and we had developed it as a testing program. And essentially, it is a combination on the application, psychoeducation videos for parents, for children, and also video calls, which means that there were sessions, possibility to do sessions during remote engagement using secure video system. And so this started as a research project, and there are many papers which looked at this research project called ECBT for children with OCD. But then when we tried to move this project, transfer from being just research project in academic setting to daily clinical practice for everyday clinician, we had a challenge, and I think many people face the challenge that our system, our ECBT, was much more advanced than the electronic record system, which was operated in every clinic. And in that sense, we had very advanced academic research project for university hospital, but to integrate into everyday practice for clinicians, several tools had to be, or we were asked to remove. So this is a challenge which I spoke previously about integration with the care when the new innovative tools are developed. Now, so this is, as I said, the app and the package rather than the app, because it also includes secure video call system, also videos, educational videos, and the app were developed some years ago. So for this reason, I want to you also not only to share my team developed system some time ago, but also the latest data from meta-analysis on randomized controlled trials 176. And this speaks about depression and anxiety. You know that in the past, OCD was also considered as a type of an anxiety, but now with the DSM-5, it's a completely different disorder. But this, I thought, a very good study, very many 176 randomized controlled trial. And this paper was published the last year in the World Psychiatry. And as you know, World Psychiatry is the official journal of the WPA, World Psychiatric Association. The editor of the World Psychiatry is founding editor is Mario May, and the World Psychiatry is number one by impact factor in the area of psychology and psychiatry. So it's a leading journal. And as I was introduced, I'm also the secretary for education and publication at the WPA, and I'm very pleased that our association has such high-ranking journal. So what this study found, as I said, they analyzed 176 RCTs with over 33 participants, so very large samples from different countries, different continents, and they found small but significant symptom reduction in depression, anxiety. So this is important. So these apps, they work when they work systematically, and CBT-based apps were more efficient than generic ones. So this finding is not surprising because we know that CBT, and also in our app, we also used enhanced CBT approach, so which evidence-based in person. Not surprisingly, it transfers well into online or smart app systems, and they were more effective than generic or people who just introduce their own ideas. And guided intervention shows stronger outcomes than self-guided, because these days in the Google Play and Apple system, there are so many self-help, self-guided apps. But this systematic review, very robust systematic review, shows that guided interventions have much stronger outcomes than self-guided. And usually, not surprisingly, authors called for more high-quality long-term studies. Now, as I said, there is a long list of the digital psychiatry tools, but for today's lecture, I just focus on the AI and also apps. So I spoke about the app my team developed for OCD, and the latest, or one of the latest systematic review from the World Psychiatry. And now I move to the AI in mental health care. I think many people use these days ChatGPT for many purposes. And one of the paper suggests that it could be used as the digital scribe, assisting with documentation, primary diagnosis, formulating initial differential diagnosis, generating plans, for example, supporting personal treatment plans, and providing patients support between visits. So this is just idea which I would like to expand and discuss a little bit more. Can I just check with you that you can hear me okay? Yeah,
Okay, yeah.
yeah. So there are always risks and considerations which needs to be taken into account. First of all, is the privacy and security. I don't need to say that. I think everybody knows that it's unethical and it's bad to copy and paste clinical data into ChatGPT and I get expect that we get some good or relevant suggestion. Of course, it's wrong for many reasons, including the patient's data protection and the validation of the AI suggested prompts. It's not based on the clinical experience or clinical practice. And of course, ethical and legal issues, they are very important because whatever we put into ChatGPT or other system, that information goes into World Wide Web, into the, it's not longer, so to speak, ours. And we still don't have proper regulation. There are some acts, but I don't think that they are final. I think as the technology emerges, there will be more and more ongoing regulations, not only in EU or US, but in all the world. What are the risks? I already mentioned that this misinformation concern, because generative AI models can be unreliable and prone to errors. These models can often spread misinformation, including inaccuracies and fabricated sources. Also, misinformation about mental illness generated by AI can include sometimes dangerous and fabricated details. And unfortunately, patients are increasingly exposed to misleading and misleading medical and mental health information. And of course, our role is to be knowledge facilitators. We don't have, as a medical doctors, it's no longer that we have a monopoly of the knowledge because now the knowledge is widely accessible. Unfortunately, as I said, online, including AI-generated models or AI-generated information can be misleading. And for us as psychiatrists, when we speak with our patients, it's very important to explain to them what information they can get from internet, and not necessarily that information is accurate, even if it's generated by artificial intelligence or some other emerging technologies. So where can AI used in psychiatry? They say that supporting documentation and paperwork, scheduling appointments. I will speak about education a little bit more, how can it be used. But of course, it cannot substitute for clinician, at least not at this point in time. So 2025 maybe it will, but not this time. And as I already mentioned, and I'll just repeat that at this stage, AI lacks real-world diagnostic validity and proven impact on clinical outcomes. So the current AI is not tested for clinical algorithms in many cases, and it lacks real-world diagnostic validity. And also, I already mentioned that non-clinical training data can lead to stigma, bias, and privacy concerns, data privacy concerns. And there is a need for proper clinical trials before we can say that this AI system is valid, and there is a need for the proper human oversight. So now I'm going to speak a little bit what we have done. And what we have done, what my team, another team is developing, it's not AI as per se, but we are using some of the models, and it's called IDEAS, or Individualized Digital Decision Assist System, for the diagnosis and management of mental behavioral disorders in children and adolescents first. And this is the team, and we have, of course, a psychiatry group, but also we have a technology group and the Institute of Data Technology Informatics, and also service users involved in this project. And our approach is so-called LEAP, local, early, precise, which we believe that may change clinical practice by making the highest level of knowledge available to the local service providers early in patients' care. So this is a complicated picture, but essentially this picture describes what we are doing. And clinical decision support system can advise clinician using information it has in the clinical guidelines form, so-called knowledge-based clinical decision support system. In this picture, it's marked in red. So we put into that knowledge-based tool current guidelines, which, for example, are used in Norway. And one of my PhD student tests that system. So it's not internet, it's not kind of open AI, it's just very, very specific guidelines, which is used in Norway, and of course, ICD criteria. And then that system helps clinicians, we started with ADD, to provide diagnosis and treatment. So this is so-called knowledge-based decision support system. And then in green, it's called data-based decision support system. So in Norway, we started electronic patient records many, many years ago. And for that reason, we have access to the database from 20 years, and we got access to big data sets. So how that big data sets work in this decision support system? For example, the idea for this clinical decision support system came from the time when I was junior doctors. And I remember when I was a young doctor and I would have a difficult patient, I would ask some senior colleague, more experienced, did you have, let's say, John, who presenting with such and such issues, and what did you do? What test did you do? What treatment did you prescribe? How did it go? Did it help or did it not help? And, senior colleague, he would think, okay, maybe 15 or 10 years ago, I had similar case and I did these and these tests, and then I prescribed these medications, and this medication first didn't work, and then I changed and I prescribed the second, and this worked better. So it's very important that we spoke with our colleagues, now junior or more experienced senior colleagues, but these days we can also ask the data. So we have now Norwegian data for the last 20 years, and we can ask the data what similar presentations, similar cases, what kind of treatment they received, what kind of information about what kind of diagnosis it was made and what kind of tests were made. And even more basic questions, for example, if such and such patient presents to GP, what are the chances that this patient would be accepted by the child psychiatry or the special services? So in that sense, this big data, which again is not open to internet or World Wide Web, it is the data which is served on our server, and we analyze and we build those models. And I have two PhD students, engineers, and one of them is finished, and another professor who supervised together with me those engineer students is a big data technology person. So we published many papers on this ideas decision support system in different journals. And of course, it's still work in progress because we find new possibilities for the big data accessible to us, but also more challenges. So this project started now 6 or 7 years ago. It's still ongoing. We have new ideas, new possibilities, and still, as I said, work in progress. What we also did as a part of this project, we several times asked the patient opinion about their data being used, because being used to support other patients' diagnosis and treatment. And I think this is very important that the Norwegian patients or service users, most of them approved health authorities storing their electronic health records. And they also see that benefits of electronic health record storage for other patients, and they have no concerns about the safety or security of the electronic health record storage. So in that sense, as recommended in initial guidelines, our team worked together with the service users, and they are very much support of the previous data being used, of course, with an ethical framework, and using and applying and also obeying the legal rules which are now available in Norway for the data use to build these new systems. So I also want to use a little bit about the AI and education. So moving now from the original work on the clinical decision system, which we work with a big data, but moving now to back to AI and open AI and education. As I already mentioned, I'm a secretary for education and publication at the WPA. So education is one of my activities, and I spent a lot of time teaching students, junior colleagues, not only medical students, but also public health students and allied professionals. So AI as educational tool in psychiatry definitely has a role. It supports scenario generation. So for example, when we need the clinical vignettes or some scenario for learning, we definitely can use it. Also for exam preparation and reflective learning. However, we have to remember that empathy, communication, and clinical judgment are irreplaceable. So especially when we deal with our students, our young colleagues, they're very keen to use, to Google everything, to Google, or now, as my students say, ask chat, which means ask chat GPT. They say, but empathy, communication, and clinical judgment, it's a human nature, so it can be done or replaced at this stage. Maybe in the future it will be different, but at this place it cannot be replaced by the technology, and we have to emphasize to our young colleagues that the clinical judgment has to come from the doctors. And also, it's very important that we teach our junior colleagues how critically appraise all the information they get from AI, from ChatGPT, that they don't take it for face value, that they critically appraise every suggestion, especially in relation to treatment and diagnosis, which comes from tools like ChatGPT. And also, I believe, and I agree with this paper published by a group of colleagues in academic psychiatry, this American journal focusing on education psychiatry, which states that AI should augment, should enhance, but not replace traditional teaching methods like lectures, problem-based learning, and others. So it is a powerful tool for education. Of course, the clinical practice has more barriers because there are clinical data, but for education is clinical or sensitive data. It's not the same usage as in education. In that sense, for education, the AI application can be more rapid and can be used. But however, it cannot replace at this stage. It can only augment our teaching and learning practices. And also, I would like to mention that the WPA has educational portal, which now has been renewed. We change. This is the old outlook, but now we change the way it looks and also revise content and also add new educational materials. So in that sense, I invite people to contribute their knowledge, but also learn using this portal. So at the moment, it's still not in operation because we renew and we revise the content. But in a couple of months, I advise you to check it because it has a lot of materials which has been collected, especially rapidly during the COVID time. So a lot of e-lectures were put into that portal, but still, even now, we can make face-to-face learning. The value of the e-learning remains relevant and high. And these are just the topics. And on this note, I would like to make some final points for my lecture. So patients, because of many environmental, internal factors are under pressure, individual and global factors, should I say, are under the pressure. But so are many services designed to care for them. There are more patients coming, the presentations can be more complex and requires more intense interventions. And for this reason, innovative approaches, including digital, are needed to make the services sustainable and empower them to provide consistent, good quality care for patients. And collaboration between services, service users, healthcare business is needed to develop innovations like digital psychiatry, and national and international collaboration is crucial. So on this note, please allow me to stop sharing my slide and switch on the camera.
Thank you. Thank you very much for this very comprehensive lecture on a very interesting topic. And thank you for this development on the website of the WPA. I have served 6 years on the board, and we were always eager to see more coming. My question is about these apps for the one you mentioned on OCD. Did you try it just in Norway, or has it been tried in other parts of the world?
Yes, so our group is international, but international in sense of the Nordic countries. So the colleagues also tried in Iceland, and then before we had some collaboration with Germany, but then, you know, everybody wants to have their own app. So Germany developed their own app, but we continue to collaborate, and there is also paper published on that app in Germany.
Thank you. Any questions, Dr. Amir?
Thank you, Dr. Walid. Thank you, Professor, for your lecture. Excellent. And there is no way then we can stop this clinical progress. It's going ahead for the last couple of years. But I do have some questions, if you don't mind. There's no doubt that the digital psychiatry and the AI devices have a lot of information, and they can manage to give some clear evidence of patients who are presenting with mental health problems. But I am really concerned about the ethical issue, the interaction between a machine and a human being. Is this machine capable of making an appropriate diagnosis? The human being and the capacity to evaluate the suffering of, as you rightly said, about immigrants and people who have been exposed to trauma, how the digital psychiatry can manage to evaluate this suffering. I heard you saying about the stigma is a problem, and definitely I agree with you, especially in camps. I work in UK, and I have seen this issue has been gradually resolving between the indigenous population. Definitely, as you know, it's multi-ethnic kind of a society in UK. There are still problems with some of the population, but the people who are really capable of identifying the problem from home and then communicating with the schools, they are capable of considering this aspect of what's called ARMS, which is at risk of mental state. I'm not sure if you had any kind of experience on this aspect of care. One thing which I heard during my work, that there are specific kind of psychiatric conditions. They are more reliable to digital psychiatry, like, for example, the ASD or the ADHD, anxiety. But when it comes to psychosis, the complexity of the issue become a serious trouble, because for me, it's not enough to listen to the patient what they are complaining of, but also to evaluate the representation in terms of body language and consideration of their affect during psychosis. Thank you very much for.
Thank you. And I think it was not only a question, but also I would like to thank for sharing your thoughts and ideas. And I agree. I think you touched two things broadly. So one is how valid is AI? How can it make the accurate diagnosis or provide suggestions accurately for the management, especially complex disorders and conditions like psychosis? And I agree with you that at present, it cannot replace clinical judgment made by experienced or even trainee psychiatrists. Of course, we don't know how it will develop in the near future because the things are changing so quickly. But I don't think that there will be a time where we will be struggling to find a job. I think we will be needed as the experienced clinicians because nobody will replace clinical judgment by psychiatrists who can take into consideration many things. And not only just, the knowledge, but also, as you said, a broader range of the factors which need to be considered when we make a diagnosis for the very complex cases. Also, you mentioned about the situation in UK and the camps and the child psychiatry. And stigma, you also mentioned the stigma. And yes, stigma is changing, and not in all communities, not in all groups to the same extent. But we also see when the stigma is changing, the schools are very quick to refer child to the special services. And maybe some problems which were addressed, like behavioral problems, were addressed by school or within the family setting. Now it's very quickly these problems are referred, or children with these presentations are referred to special services. And I think this just shows that the collaboration and our role as clinicians to provide education for the schools, for the parents, is even more important because the child, he spends most of the day or half of the day at school. So what happens in school is very important. And then the family also takes an important role because even the doctor prescribes medication for the child. It's the parents who decide when and how this child takes those medication at home. So I agree with your thoughts about stigma too. So thank you very much for your comment.
Thank you.
Dr. Hassanin.
Thank you, Dr. Walid. Thank you, Dr. Norbert, for the interesting presentation. Hassan Al-Tayar, forensic psychiatrist from Oxford, UK. I would call it the LAI, limited artificial intelligence, because it will have some limitations. Like when I do a case in forensics, for example, and I try to use AI for fun, really, and I give the computer a scenario and say, okay, this man has done this. What are the psychiatric defenses in this case? And he will give me straight away, for example, diminished responsibility, which in the UK, diminished responsibility is only applicable to murder. So if the offense is something else, like arson or sexual offenses, it will still give me limited or diminished responsibility. Same applies if I say the patient is hearing voices, and he will give a diagnosis of psychosis. Well, as we know, voices could happen in a variety of other conditions, trauma or emotional instability, personality difficulties, and things like that. So it's a very interesting field, but I think there are some limitations, of course. I think for us and trainees, if we want to benefit from it, is probably to be mindful of the limitations and not to rely solely on it for clinical use. Thank you.
Yes, very good comment. And also, it depends. The AI generates the information also very careful. Depends what information you request. Anybody, because I'm not referring to you personally. So I think when we speak for educational purposes with our trainees, we have to teach them how to formulate question in a very precise way, because if you write the question kind of vague question, you will get the vague information. And sometimes, you know, I don't know if you tried it, but sometimes you can write to ChatGPT, I think you can do a better job. And the ChatGPT tries to do a better job on your question. So there are also ways how to get ChatGPT or other AI work harder. But of course, there are limitations. Even ChatGPT works very hard.
Thank you.
Any other questions or comments from the audience?
I mean, for me again, where do you see the future of this going? I mean, what do you think in a few years' time? Do we have any view about what would happen? And probably the question is open to everyone, not only Dr. Norbert.
I think Dr. Jalal raised his hand. He maybe has the answer. Let's hear from him.
Yeah. Go ahead, Dr. Jalal.
Please.
Thanks a lot. I really was working in a team for digital mental health for northern Syria. We were psychologists, and me as a psychiatrist and psychological counselors. We were a multidisciplinary team on something called a project called mental health online, mental health services online. Really, there was some problems that the people were mistreated by some people who make frauds for people who were not trained, and there were harassments, there were really violations for the people. And you know, in our third world, there is, I think, most of the countries, there isn't a law for internet crimes, and that really affects people. And there is many risks and hazards that relates to our context. Lacking or loss of legal system, that's one thing. Nothing protect people if there's any violations or harassments. People are not well trained. They aren't trained for the clinical boundaries and for the techniques that should be applied for that kind of relations, either for the adults or for the children. So I think we have more hazards, more things, and our systems of communication, of internet communication, digital psychology and psychiatry are insecure. So I think the privacy and of the people and their information are at risk of not dealt with in a secure way. So I think we should talk, when we are talking about Norway, Europe, and the people, they are well systematized and in a legal context. I think it is more dangerous in our countries. Thanks a lot for you.
Yes, and I think, you know, your questions or your thoughts bring me just also another thought about the cultural adaptability of the information the AI generates. Because even when we speak about the evidence base, for example, when we talk about the trial medication, biological therapies, but for example, all the CBT and others, they are coming from so-called Western world, United States, and then also Western European, the big European countries. But then when we speak, especially for the child psychiatry, the majority of children actually live in East Africa, in India, in other countries. So, but then the evidence base is coming from other parts of the world. So how easily, especially when we talk not about the biological interventions, but about the therapeutical talk therapies, how easily they are adapted in a different cultural setting. And that also, I think we can extend this to the information which goes to the ChatGPT, because I think many things which goes into AI, the information, the models, they're coming from so-called, developed countries. And then they're not necessarily the cultural norms, the environmental norms automatically applies to other settings. And I think that's also the challenges together with the legal issues, which are very different from one region to another region. You just explained. So thank you very much. I think we have it.
Last question, Dr. Muhammad.
It's not a question, actually. It's a comment to resolve this conflict. I'm here in Germany. I worked as a psychiatrist, as a psychotherapist, and then I got a master in medical law as well as in hospital management. And my master thesis was in how Germany can benefit from telepsychiatry. And here, when we talked about digital psychiatry, which include telepsychiatry. Through this master, I investigated actually the application of telepsychiatry in many countries, including India. And this is very important with the huge population, with also the different standard of socio-economic standard to European countries. And I found that the Indian actual experience is I could classify it as one of the leading experience in the world in using telepsychiatry in combination with other application of digital psychiatry. The problem that we don't have in our countries, in our Arab countries, actually a solid regulation of internet therapy or internet clinical application, I mean telemedicine. But still, if you, for example, hired a doctor from Germany, according to the German law, although that he is providing the service through telemedicine to a patient in Egypt or in Syria, he still can be held accountable here in Germany. We have to understand this aspect of legal application. Anyway, we in our Arab countries, we still need the human being. So I think that there will be a good opportunity for telepsychiatry to grow or telemedicine to grow in our countries, in our Arab cultures, will be more accepted than the digital, other digital solution, because the human being is still there and still can be held accountable. Only the problem of infrastructure, I mean communication infrastructure, can obstacle that in some countries. I wished if our lecture today have also included the use of telepsychiatry or telemental health as a big issue, not just like just a small address. Thank you.
That's just a lecture for the next time.
Yeah.
For Dr. Walid's suggestion.
Thank you very much. Thank you, Professor, for your presentation. One of the most educative lectures in this new field, and I hope we will be talking about it more elaborately in the near future when things are more clear and organized. Thank you again. Thank you everybody for your participation and attendance. And I wish you a pleasant night. Thank you.
Thank you.
Bye-bye.
Thanks.
Bye.